Yeah, thank you for joining us today for our Centre for Care seminar. I'm really pleased to welcome Dr Tanja Ahlin from the University of Amsterdam. She's based in the Department of Anthropology and is a postdoctoral researcher on human factors and new technologies. And today she'll be talking about Transnational Care Collectives, digital technologies for elder care in Indian nurse families. Without further ado, I'd like to welcome Tanja to present, please.
Thank you very much for this introduction and also for the invitation to have me. Now let me share my PowerPoint with you. Do you have it? Yeah? Okay. Thanks, Kate. As Kate said, my name is Tanja Ahlin, and I'm an anthropologist. And today I will be talking about the work that I have been doing for almost a decade. And that's started as my PhD research. And then it's accumulated into a book that was published last year with Rutgers University Press, and that it's titled Calling Family. So that's on digital technologies and the making of transnational care collectives. And I will be talking about that concept of transnational care collectives about a bit more specifically today. So, right. So there are several assumptions that I'm addressing with this work. And these are not exhaustive, but the most important ones that you can see on the slide. So the first one is that care is possible only through physical proximity of people. So people have to be in the same space to be able to take care of each other well, right? And I mean, these are the assumptions that I've come across at the beginning of my research when I was reading all kinds of literature, and that kind of stood out to me, but also when I was talking to people. Both in my field and practically anywhere. This one, that care is possible only through physical proximity, that's quite common in aging and care studies. Also if you ask people like healthcare workers or even family members, that's often what you will hear. So that care is basically not possible when people live far away from each other. Another assumption that I've come across is that care is only a matter of people. So it's something that people give to each other and receive from each other. And the philosophers of care, so the ethics of care philosopher Joan Tronto, for example, she writes about how care is one of the core characteristics of being a human person, of being a human. So with this work, I challenge this assumption a little bit in the sense that it is very important for people, clearly, and it is a characteristic of being a human, but there are also material objects that are involved in care, and I will show how. The third assumption that I'm addressing is that cheap calls are the social glue of transnational families. And that idea became very popular in the early 2000s or so, 2000s, in the transnational studies. So at that time, it was true that the international calls, telecommunications were really becoming much more inexpensive, and that led to people, being able to call each other from all parts of the world. So I'm not trying to suggest that cheap calls were not important for transnational families, but I am wondering about the social glue as a metaphor, like the best way to talk about this. And I'll come back to this later at the end of this talk. The next assumption that I've come across is that care and healthcare are two distinct phenomena. And that, of course, is also very common when we think about, how they are separated into formal care and informal care. And these two types of care are also differently paid, and they follow different professions. So the formal healthcare requires degrees in nursing and medicine and so on. And it is paid through insurance. It is sometimes paid by the government and so on. And care is much more often delegated to the informal sector, and it's also not, perhaps not as well paid, and often provided by family members, and not even paid all the time. So I want to challenge that idea that these are always like that these are strictly two distinct things, because in my case study, I found something else. And then the final assumption that I want to mention is that idea or a promise or a hope that's very common when we talk about technologies in healthcare or care in general, and that is that engaging technologies in care will increase efficiency and decrease costs of healthcare. So if we think about things like telemonitoring, for example, the governments and the technology developers have often thought about or believed or hoped or promised that if we include technologies and, for example, the nurses don't have to physically visit their patients who live all around the country, for example, to check on them when they have chronic patients. But if they just monitor them through a specific system, that, this kind of a system would then decrease their travel time, and therefore we would need less nurses, and the whole system would be cheaper. And that, of course, hasn't.
Yeah.
Can you hear me?
Yes, I can now.
Yeah, you can. Okay. So, as I said, I became acquainted with telemedicine about 15 years ago, when I learned about how the systems were being developed and implemented. And I went to quite a few conferences on the topic, and I found that there were so many telemedicine projects that were very successful in the pilot stage, and that was all around the world. And basically, the story was, repeating itself. So they were successful in the pilot stage, but then there was usually a problem when they had to be implemented at a larger scale. And I was really curious about why do we have to spend so much money and time and energy into developing this completely new, highly sophisticated systems for healthcare, if we already have everyday digital technologies that people use on a daily basis, and that are perhaps not available and accessible to completely everyone in the world, but to a great majority of people. So I started to develop this project actually as a sort of a reaction to what I was learning about telemedicine and telemonitoring and telehealth at that time. And I said, well, let's look at these mobile phones. At that time, there were very few smartphones, if any at all. And I said, well, how do people already use these technologies for care at a distance? And what do these technologies actually do for care? Or how do they change it, and so on? So I was looking for a nice case study for this. And of course, transnational families were clearly a very nice option. So transnational families are families in which members live all around the world, spread across different countries and continents. And I chose one specific ethnographic case study, which were nurses from Kerala, South India, who migrate abroad for work. And as I said, I wrote about this in my book. So this is a very extended ethnography, and I will just talk about some of the most important points from this book today. So why are the nurses from Kerala so interesting? Well, the female labor migration has definitely increased significantly all around the world. And in Kerala, nursing in the past 3 or 4 decades has become really a major migration strategy, and especially for women, but then lately also for men. And of course, this falls into this literature on global care chains, or specifically on global nurse care chains, according to which women from, people in general in so-called developed countries would hire care workers, nurses, and also domestic workers from the so-called less developed countries. And of course, these people, these carers, would also leave behind people who would be depending on them. So in the global care chains, usually these people who are left behind are children. But I decided to look at what happens to the parents of these adult children who migrate abroad for work. And I also found the literature by Kreger and Schroedel very interesting here. They talk about de facto childlessness. So that refers to people who actually do have children, but whose children have moved far away, and they actually have to organize their lives as if they didn't have any children. So I was wondering if that was still the case when digital technologies come to the rescue, so to speak. And another thing, it was also interesting to observe how these flows of nurses change together with the global economic and political flows. So, and a very important example here is, of course, Brexit. It was fascinating to see how at around 2017, for example, the number of nurses in the UK, the number of nurses from Europe dropped significantly, very sharply, all of a sudden. But at the same time, the number of nurses from India increased to almost the same level. So along with that, so, you know, one reason why that happened was because the British government also decreased or adjusted the requirements for nurses from India. So on the right side here, these are 2 posters that I found circulating on social media. And also, you know, the nurses from India, they would circulate this kind of advertisements in their WhatsApp groups and so on. So on the right side, you see a poster or an advertisement for jobs in the UK. And there you can see required IELTS 7 for all modules, right? So IELTS is the English language test that all nurses from India have to pass. And to achieve level 7 in all modules, that's listening, speaking, reading, and writing, that is a pretty difficult task, actually. So lots of nurses were not successful in migrating to the UK, but after Brexit, this was lowered. I don't know to what grade exactly, maybe it was 6 or 6.5, but it became much more doable for nurses from India to actually migrate to the UK. And on the left side, you see an ad for Oman, and this one actually doesn't name any kind of language requirement. So there was actually a whole hierarchy of countries to which the nurses would want to migrate. And on the top were usually the English-speaking countries for a number of reasons, also because they allowed for permanent residency, they allowed for pensions, and also to bring along family members. But then if the nurses didn't succeed in migrating to one of those countries, then they would also consider countries in the Middle East, such as Oman. So these countries were kind of historically very important for migration from Kerala because of the physical proximity as well. So to do this research, I did ethnographic fieldwork. I went to Kerala, so I stayed there for 5 months in 2014 and 2015. And I also followed some of these nurses to Oman. So I traveled there, I was there also for 3 months. And then something else happened. When I was in India, I was actually invited by the families themselves to start talking to their family members all around the world. So they would all of a sudden put me on the phone to talk to their daughter in the Maldives, or they would put me on Skype calls with their nurses, so with their daughters in the UK and so on. So I found myself talking to nurses that lived in Canada and the US and Australia and New Zealand, also in the UK. And then I really started to wonder where my field site was, because it wasn't very clear. And so I came up with this idea of field events, which explores how the field site changes, changes its focus from being very clearly grounded in a particular physical site, geographical site, to being kind of spread across different geographical sites when using different kinds of technologies. And that's something that I write about, and that I can also talk about later if there's interest. So when I first landed in Kerala in 2014, and I found some, I was looking around for people to talk to. And I said, well, I'm looking for people who have, so older people who have children working abroad as nurses, and specifically in Oman, but also in other countries. And there was one person that I remember very distinctly, because he laughed at me and he said, oh, it's impossible. They will never talk to you. And I was really shocked at this impossibility of doing my research. And he explained that the reason why these older people wouldn't want to talk to me was because, they were going around and they were telling everybody, oh, I have a daughter in Dubai, I have a son in the US, and they were very proud of their children being abroad on the outside. But on the inside, he assumed they would be very lonely and isolated and actually abandoned. And, these children left to earn high salaries, but the parents were at home and they were all devastated and, abandoned. Nobody would take care of them and so on. So I was really surprised when about a week later, I was actually able to set up an interview with Alice. So Alice was a widow in her 80s, and she lived by herself. And she had a son in Dubai with his family, and her daughter was a nurse in Australia and also had a family there. And when I asked her, she didn't look actually sad and lonely and isolated at all. She was very active in her local community. She went to the church. She was engaged there with the singing choir and so on. She had a beautiful house in which her children would come and stay once in a year when they visited. And she had a beautiful garden to which she tended to. And then she didn't look, unhappy or depressed and so on. And I asked her about how does she feel about her children being away. And she said, she got a little bit angry even, like I could feel it. And she said, well, because my children are abroad, I'm living happily here. If they live here and have no jobs or earn a very poor salary, would we all be happy? No. So, and that kind of opened my eyes about this discourse of abandonment, which said that the migrating children were abandoning their parents, and the parents wouldn't want to talk badly about their children, because that would actually mean that they were that they raised children who were really oriented towards cash rather than care and so on. But clearly here something else was happening, right? And when I talked to some other parents, they said, well, yes, we struggled hard to get our son educated. And then when he completed his education, the nurses were paid very little here. So since he's gone abroad, I'm extremely delighted. And this was actually indeed the case for many women, many parents. And so I found that for these families, migration wasn't really seen as an act of abandonment on the part of their children, but it was reinterpreted as a care practice in itself. So because the nurse salaries are so low in Kerala, they have been increased since the beginning of my fieldwork, but still they are very much on the low side. So the adult children who were nurses there, they weren't really able to effectively become carers for their aging parents, because they could barely often survive themselves, right? And there are reasons for the low salaries, of course, that I can go into later. So it turned out that migration is not really something that the children would just decide on the spur of the moment, well, I want to migrate, so that's what I will do. It was not so much, it was not at all an individual choice, but it was often a family endeavor. So the parents would be very much invested into their children migrating abroad. And I often came across these idioms of sacrifice and suffering. And both the parents and the children would say, well, you know what, we sacrificed and suffered so much to get our children educated. We had to take loans, or we had to work hard, so that they would get the education. And then they also had to often finance the migration process itself. And, that is something that the parents do. So they were engaged in this process themselves. And then the children felt obliged to repay this suffering and sacrifice on the part of the parents. And they did that in several different ways. So these are some of the very concrete practices, right? So they had to finish their nursing studies, they had to pass the IELTS test, if possible, and then migrate abroad. And if they didn't pass the IELTS test, they would still go to some country where this was not a requirement. And then once they were abroad, they were repaying the suffering by sending remittances back home. And you can see the impact of that, right? In these different houses that you see here on the slide. So when I asked people there about these houses, I would show them these pictures, and I said, well, do you think that there's somebody abroad in this house? And they would exactly be able to tell me if there was anybody abroad, where they were, how many children were abroad, and for how long. So that all was reflected in this in the houses and also in the cars. So another very important practice was for these children to visit regularly, and that was usually once a year, sometimes more, sometimes less, depending on where the children were geographically and how much leave they would get from their work. But, as long as it was possible, that was something that they were kind of expected to do. And also they had to call home frequently. And that's what I will focus on in the coming slides. So in my work, I reconceptualize care with the help of theories that come from science and technology studies, and specifically this theory of material semiotics, which looks at care not as something that is given or received, but actually something that is enacted within very specific practices that involve not just people, but also non-human agents. And in my study, what really became very clear is that these non-human agents are digital technologies and also money in the form of remittances, but also in the form of investments, right? So these two non-humans are what kind of the major actors in transnational care. And I came up with this notion of transnational care collectives, which is based on the notion of care collectives by an STS scholar, Miriam Winons, who used it in her studies of disability. But I kind of built on this concept and made it about transnational care collectives and digital technologies. Now, transnational care collectives involve parents in their homeland or wherever they're based, but usually in their homeland, and their children abroad wherever they are based, and also sometimes, the siblings who are not abroad but in the same country, and the digital technologies that they use to enact care. And every one of these transnational care collectives has its own dynamic, and the family members would establish this dynamic through tinkering. So they would try out for a long time, they would try out different technologies to find what suits best to whom. They would tinker with different time zones. They would tinker with different schedules. They would, for example, take into account not just the work schedules of the children abroad, but also the activities that the parents had at home. And then they would also tinker with different kinds of people who were involved in this care collective. So I mentioned the parents at home and the children abroad, but then other people were also engaged. And sometimes these were family members, but they could also be neighbors. They could also be grandchildren. So I'll talk about that later on. So to start with, these are some of the different kinds of technologies that were used in the families that I visited. So this is a collection of phones that a young nurse who was still living with her parents in Kerala showed to me. So she had all these 4 phones, but she was only using the one with the picture in the middle. And she already had 2 sisters who were nurses in the UK. And I asked her, why are you keeping all these phones? You could have sold them or, given them away or whatever. And she said, no, I am keeping these phones because I want to show them to my nephews one day, so they will see how well my sisters took care of us. So it was the children abroad often who bought this kind of technologies and also paid for telecommunications. So they paid for the internet, they paid for mobile phone subscriptions. And this in itself, like buying and gifting these technologies was already a care practice in itself. But then, of course, the parents in India had to take care of the technologies as well. Right, so they had to make sure that the batteries were filled, and they had to make sure that the credit was there, and so on. And then it turned out that there was a new care practice in this kind of context, which was calling. So, when people were not able to live together, so in India, one of the major care practices for elder people is to live together, to prepare food for them, to share food with them. So these are all indeed practices that require physical proximity. But in a transnational care collective, in a transnational environment, this of course is not possible. So what becomes a new care practice is calling. And one of the nurses living in the UK, and then he moved to Australia, he said, well, I think the most important part of care is the understanding. It's the trust. It's not touching. It's not giving money. I call them daily. That's a gesture. That's a way in which I show my love. So I find it very interesting because he emphasized that care was not even about giving money. He found calling much more important than that. And through frequent calling, establishing the trust to share with them all the details of his life, and they also shared with him the details of their lives. And of course, the frequency of calling. So, what is good care? If calling is care, what is good care? It depends on how frequently you call. And of course, that is something that was also established in each family individually, right? And it was also different sometimes from one sibling to another. So Sarah, who was a nurse in Oman, she told me, well, if I don't call for 2 or 3 days, and even if it's because of my work schedule, then my father would say, are you also becoming like your brothers? You're only calling us weekly now. So Sarah had 2 brothers. One was living in Ireland, and another one, I think, also in the UK. And she was the only one who was actually calling every day. And she had a very particular schedule. She would call her daughter, who also lived in Kerala, at 5 o'clock, and then she would call her parents. And she really had to adjust this calling time to mass, so to the prayer time, and also to the TV schedule, because her parents were watching specific serials and so on. So that was also something that was established through time. And then, of course, you can already see that there was a difference between how often the daughters would call and how often the sons would call. Now, what did the people talk about when they talked every day, or sometimes more than once a day? Well, it turned out that that depended actually on the type of technology that they were using. So if you are talking on the phone, silence can be very dangerous in a sense, right? Because you don't know if what is happening? Is there something wrong with the connection? Is that the physical connection that's not working, like the actual lines are, you know, not working properly? Or is there something with like the emotional connection that is not going well? Is the other person maybe angry or upset, or and so on? So what people did was they learned how to talk to each other on the phone so frequently, and they did that by sharing the everyday small things of their lives. They talked about the church that they went to, what happened, like who got married and so on. They talked about the garden, the plants that they were tending to. They talked about the neighbors' children. They talked about the food and so on. So, but these are not really, you know, the insignificant details. Like it turned out that this was a way of sharing their everydayness when they were living far apart. So they were quite significant conversations, I would say. And then again, if they were using the webcam has a sort of a paradoxical impact on people and how they communicate to each other, because sometimes they wouldn't even have to talk if they had the webcam turned on. So I was sitting with a family in Kerala one day, and they called their daughter, who was traveling in the car, in the backseat of the car, and they exchanged some details about their lives. But then for a while, we were all quiet. So they were talking on the smartphone camera in the car, and they had a laptop, the one as you can see in the image, and they just had the webcam turned on. And for a moment there, for quite a long time, nobody said anything, and it felt sort of as if we were all traveling in that car through London. And I really needed some time to wrap my head around this, like what was happening here really. And so I came up with this expression of, you know, people are actually spending time together on the webcam, and they can do that by engaging in other things, like you know, maybe just sitting on the couch, but also maybe cooking or doing other things, and not even talking to each other, but spending time together nonetheless. Now, to talk about who else became involved in the Transnational Care Collectives, I find this a very interesting example, because the sons who lived abroad would often engage their good friends to drop by every once in a while to visit their parents with their smartphone or a tablet, and they would establish a video connection with them. And one reason for that was that they really wanted to see how their parents looked like. It happened quite often that the parents would more easily share their health problems with their daughters than with their sons. And one of the mothers told me, well, you know, we had this accident. The father had a serious accident, and he actually broke his shoulder and had to undergo an operation, but they didn't share this with their son. So the son was really upset when he came home after a couple of years, and he could see the scar after the operation, and he realized that they didn't share that with him. But the mother said, well, you know, why bother him? He lives so far away. It's not like he can come running immediately. So they didn't want to stress him. So, and the sons realized that actually, that they kind of predicted this, and they asked their friends to set up this connection so that they would also see them in person. But interestingly, none of the daughters ever mentioned something similar to me. So it was much more common to share this kind of, not always, but more common to share this kind of things with daughters. Now, here is also an example that I want to mention, because it shows so clearly that you know, the line or the border between care and healthcare is not very clear. And also what we understand as a care practice, you know, sometimes it may not be very clear, right? Or a practice may not appear as a care practice at first, but then it turns out that it's very important for care and for healthcare. So he told me Aaron was an only son living in the UK, And his father had a chronic lung disease. So he was very much invested into taking care of his father's health at a distance. But he'd also told me, when I'm in Kerala, I just invite my friends for a drink and we have a kind of a party. And why was that important? Why was that a care practice after all? Well, because when Aaron's father got COVID, this turned out to be super important because Aaron was actually able to take advantage of these links, these friendships that he was maintaining. And this was crucial to be able to get Aaron's father into the hospital and to find a bed for him. So he told me, well, I asked one of my friends who is a member of a local political party to call the hospital and talk to them. And that's what he did. And it was really important because in that way, they found a bed for him. And otherwise they said, well, there's no bed, it's impossible. He does need intensive care, but it's not possible to take him in. But, Aaron really activated all these connections to make it possible. And it was really a matter of life and death in the end. So the father survived. And Aaron said, well, that was absolutely crucial to get my father into the hospital at that time. So to recap in a nutshell, what are the Transnational Care Collectives? Well, these are global assemblages of people and technologies that enact care together at a distance, and they do so within practices such as frequent calling, but also sharing everydayness on the phone and spending time together on the webcam. And these collectives are dynamic. They change through time. They change not just through tinkering at the beginning when families are trying to establish new norms of good care, but also later on as perhaps the parents' health changes with age, or even through events such as the COVID pandemic, when the dynamic turned more towards caring for the children who were abroad, because then all of a sudden they were the ones who were, as nurses working in the hospitals, much more in danger. At least that was the perception of this family. So the parents suddenly started to take care of the children and asking them how they were and giving them advice and so on. And transnational care collectives are also established not just through digital technologies, but through other non-human actors. In this case, money was quite significant, and they are maintained through affect. So lots of people actually told me that it's really about how you feel for your family members and so on. So that in the end was what kept these families together, right? So just to give you a very brief example, many of the older parents were not very versatile with digital technologies, but they did want to learn about them. They wanted to have the internet installed in their houses and so on, and they wanted to learn how to use it and so on, because they wanted to be in touch, not only with their children, actually, but especially with grandchildren. And this was especially true for grandmothers, so they said they would do anything to be in touch with the grandchildren, even if it was, sometimes it was by calling them on the video, or sometimes it was about watching the photos that they had uploaded on their children would upload on iClouds and so on. So to return to the assumptions, I would argue that when people live in different countries or are separated by geographic distance, it doesn't mean that they necessarily care less, but they learn how to care differently through the practices that I described. And then this care is clearly not only about people, but the material objects really shape it in significant ways. And sometimes it can be a matter of life and death if you can arrange, for your parent in need to go to the hospital on the phone and so on. And then about the social glue, I would say that perhaps it's not only the cheap calls that matter, but it is really affect that is the social glue, because for the moment still, this kind of devices don't just get up and call by themselves. Maybe they will in the future, who knows? But I think that affect here is still the great motivator. So that's something that motivates people to actually pick up the phone and call. And affect is not only, of course, always positive. It's not always about the warm, fuzzy, good care, right? But it can also be about different things like feelings of obligations and so on. So, there's the whole spectrum of affect that is important here. And then the small and seemingly insignificant acts of care, such as inviting your friends for a party, to maintain this relationship with them, can have a significant consequences for health, as we saw with Aaron's case. And finally, technologies don't really necessarily decrease the workload, but they change the routines of care and also require new skills. So it's not like the people involved actually need to, care less or do less work, but they need to learn how to, what can be done, what kind of care can be done at a distance, and how to do it well. So that would be all from my side, and I hope it's within the time. And